I've just delivered a session regarding the key issues for people with dementia in the acute hospital. Actually, these are several folk, but the main things I've discussed to begin with is that the environment for the acute hospital is actually not good for people with dementia. It's not built for people with dementia, and we need to think about people with dementia and their needs more often than we do at the moment. So simple things like signage highlight need to be actually effective for people with dementia. We need to step in their shoes and actually think about what their experience would be like. Another important part is about communication, about we have set rules and routines in the acute hospital. Well, people with dementia aren't going to fit that routine very easily because actually they're sort of driven by a different beat in some respects, and we can't expect them to adapt to us. Instead, we need to adapt to them. And that could be changes regarding about how we speak to somebody, so we're not telling people, we guide them, we validate their experience. And that's really important, trying to actually work with the person rather than having these set rules and routines. Always in dementia in the acute hospital, we have to be thinking about delirium, the acute confusion on top. And what I've just spoken about is highlighting how we're not particularly good in recognising that, identifying it, and then also managing it. And that partly comes down to medication. We tend to over-medicate, and we tend to choose medications that actually aren't helpful for people with dementia. So something we talked about today is the anticholinergic burden scale. It's a weird world where we're looking to perhaps give people with dementia medications that can help boost their cholinergic system, and yet we're also giving other medications for other reasons that actually impair the cholinergic system. And we have to think about that. We actually make better choices. And what I've been saying is there are some medications that we should never be using for people with dementia because actually in the long term it does them harm, and there's good evidence to show that we increase their mortality rate and we impair their cognitive function further. The last aspect really highlighted about discharge planning. This is something I'm very passionate about. We've got to do better for people with dementia to get them living in places where they want to be. And again, too often with discharge planning we take too long. People are in the wrong place for too long, and instead we should try to be promoting them returning to home. Many people who are quite impaired with dementia can still live at home very safely, but we need to manage the risks. I'm afraid we live in a world where it's never that there's no risk, it's about managing those risks. I've always highlighted my final slide that I spoke about, it's highlighting the NHS document, Nothing Ventured, Nothing Gained, which is an incredibly useful document in dementia care to actually look at us all as a group of professionals and families as well of helping manage those risks of people in the community. Because the long-term aim is got to be for people with dementia to live a life as full as possible and to be where they want to be. I think the key message we really want to get across is that we need to think about how people with dementia cope with being in an acute hospital and the adaptations that we need to make to help them and to reduce their distress whilst they're with us.